Thank you for joining us. I'd like to welcome you all to today's webinar talking about SBIRT for adolescents, an upstream intervention to address the heroin and prescription opioid epidemic. At this time, I'd like to go over some housekeeping items for today's webinar. If you have questions for our speaker or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. 1 hour following today's webinar, you will receive the evaluation and continuing education request information. This webinar is approved for 1 PCB and/or NADAC credit. You will automatically be issued a certificate of attendance, which will be available for download from your MyRetta profile. I will go over all of this again at the conclusion of the webinar. At this time, we will go through 4 poll questions. We'd like to get a picture of the demographics and SBIRT experience of the audience. These questions will appear on the screen as an interactive poll. Please select the best answer as it applies to you. The first question is, what is your current professional role? Counselor, therapist, social worker, or case manager? Nurse, nurse practitioner, physician, or physician assistant? Program or unit administrator, university student or faculty, or other. And if you've chosen other, we would welcome you to chat with us via the chat pane or the questions pane to let us know what your role is, and then we will share that with our presenter. All right, so it looks like most of you joining us today are counselors, therapists, social workers, or case manager, and an equally representative portion of you have selected others, so we're curious to hear what those roles are. We also have some nurses, some program or unit administrators, as well as some university students or faculty. Our second question then is, which field do you represent? Mental health, addictions, physical health, education, or EAP? All right, so it looks like most of you represent the addictions field, with a 23% of you in mental health, an equal portion to that in education. Some people here with us who represent physical health, and some who represent EAP. Our next question then is, do you conduct SBIRT interventions, yes or no? %40 of you are currently conducting SBIRT interventions, and 60% of you are not. Our final question then is, do you see your agency using SBIRT, yes or no? %77 of you said yes, you do see your agency using SBIRT, and 23% of you said no, you do not. Thank you all for completing the poll questions. We will be recording this webinar, and at this time we will begin the recording. I would now like to introduce our presenter today, Brett Harris. Brett is a clinical assistant professor at the University at Albany School of Public Health and Suicide Prevention, Program Manager at the New York State Office of Mental Health. Dr. Harris has over 6 years of SBIRT research, program development, implementation, and evaluation experience with New York State and national organizations. She has co-led the IRETA SBIRT for Youth Learning Community since its inception in January 2015. At this time, I will turn things over to Brett, and we will get started with today's presentation.
All right, thank you. Hi, everyone. I want to thank you for joining me today for this presentation. And I think this is a really good opportunity to talk to a bunch of people who are familiar with SBIRT and who are working in the SBIRT field, so we can come together and talk about how we can use SBIRT to address the heroin and prescription opioid epidemic. So I don't need to tell you that this is a major public health problem right now. But just to give you this message right up front, and this is really where the gist of this presentation is going, is that there is a place for SBIRT to address this, and it's not just in screening and identifying people who are abusing opioids and getting them into treatment, but there is another place for it, much more upstream. So I'm first going to go over some statistics that really describe the problem and where the problem is. So as you can see, that this is really eye-popping, and that you can see that top line is drug overdoses. So this graph is showing the % change in age-adjusted death rates since 2003. So every year, as it gets farther away from 2003, it's showing the change in deaths in the death rate since 2003. And there really is. There's one other line that's showing an increase, that's suicide, and I also work in suicide prevention, so these problems are in tandem, and this is really catching our eyes, and we're trying to figure out how to best address this. The other thing of note is that these other diseases, heart disease, cancer, stroke, these are the things that traditionally have gotten the attention of public health, the medical field, and have gotten a lot of dollars to help prevent these things, and they have shown decreases, and including all-cause mortality. Now, zeroing in on drug overdoses in the United States, the age-adjusted death rate, this is not the % change, but the actual rates have also, you can see here, showing the increase in the actual rates between 1999 and 2014. And in 2014, there were over 47,000 drug overdose deaths. And then breaking it down by gender, specifically in 2014, you can see that about 3/4 of them, or 2/3 of the deaths were among men. And the age-adjusted death rate is 15.6 per 100,000 population, compared to only 8.6 among women. Now, this is a very interesting way to look at it, and I am very interested in data, and I don't know who's familiar with CDC Whiskers database, but you can see on the bottom of the screen that the link is provided, and you can find a lot of information on this. It also breaks down by state, so if you want to paint a picture like this when you're trying to demonstrate the problem, you should definitely use this link, and if you have any questions about how to use it, you can contact me after the presentation. But you can see in the lighter green lines is the white population. This is typically among men, because as I showed you on the last slide, there's many more deaths among men. And this is also the same in suicide. So kind of honing in on this population, you can also see that how it works with the age group. So among white men, you can see on all the way on the left, adolescents, you're thinking, well, it's not really a problem among adolescents. But in terms of prevention, you want to start before it becomes a problem. So ideally, you can see right here that we need to begin in adolescence. But it increases steadily in young adults, 20 to 24, all the way up to 30 to 34, and kind of plateaus a bit in the middle years, and then starts to decline. A similar pattern is found among the American Indian and Alaska Native, the yellow line. So it is, the death rate is lower than among white men. And then among black men, there's an increase, but the numbers are smaller. As you can see, it's a little bit of a different pattern in that it increases in the middle, about 50, 45 to 49, 50 to 54, and 55 to 59 where it peaks, and it starts to decline a bit. So you can see different patterns, and in terms of targeting populations, probably different approaches. But we have, among young people, young men, especially young white men, we have an epidemic that has really caught the attention of the public health, substance use field, the medical field. Now, in terms of race and education, this chart comes from, you can see on the bottom, Case and Deaton article that came out in late 2015. This is really actually caught the attention of the candidates for president, and this was brought up a few times in speeches. And among really among white middle age, there's been such an increase in three things: drug overdoses, liver disease, chronic liver disease from alcohol use, and from suicide, so large that it's actually increased all-cause mortality among white middle age. So this shows poisonings, which is referred to, is the term used for drug overdose in this article, intentional self-harm, which is suicide, and then chronic liver cirrhosis. And taking a look at poisonings, you can see that particularly among the less than high school or high school degree only, there's been a large increase over the last 15 or so years among the middle-aged population among whites. And of course, there has been some increase among those with some more education, but it's the greatest in that age category, or in that category of education. And then you can see this is an issue in our country. We have all-cause mortality decreasing among this population in all these other industrialized countries, but not in the United States. And you wonder why I'm bringing up all-cause mortality and not just drug overdose, because these three problems, as I said, with drug overdose being one of them, has really turned around the trend of decreasing all-cause mortality, which is now increasing. And just to note as well, the CDC also looked at some data around maybe in February of this year, saying that this same trend has been found among young whites as well, young adult whites. Now, zeroing in on opioid use, so the data just came out for 2015, and of course it has increased from 28,647 in 2014 to 33,901 in 2015. So heroin overdoses have increased by 23%, and this is more than a tripling since 2010. Synthetic opioid overdoses increased by 73%, and a lot of this is due to fentanyl, which I'll talk about briefly, and then prescription opioid overdoses really only increased by 4%. So the press release that came out with this was talking about it really plateauing of the prescription opioid overdoses, and then contrasting that to illicit opioid overdoses, there were 19,885 deaths as a result of that in 2015. So why? The story that we're hearing over and over again is that there has been a rise in opioid prescriptions. So people get more prescription drugs than they need, and they take these opioids and they get addicted. And because of this past misuse of the prescription opioids, they start using it when they don't need it, and the cost or inability to get it, and the increased availability of heroin, which is at a lower cost, they then turn to use heroin, and heroin is of high purity. And then more recently, fentanyl is a synthetic opioid with high lethality. It's been laced with heroin. So a lot of times, even a first use of heroin that has fentanyl in it with that high purity and lethality is causing these high numbers of drug overdose deaths. So this, and I'm sure you're well aware, has caught national attention. So I'm not just talking about recently, but over the past couple of years, it's been in the local newspapers and the as well as the widely read newspapers like the New York Times. It's there's been personal stories about families who has a loved one that has died of an overdose. There's stories about people that have abused these drugs and have been in treatment, and have some who have recovered and some who are still trying to recover. The news stations have been covering these stories as well. There's also been some documentaries that have come out, namely one of them, Heroin, Cape Cod, USA, came out a year or so ago, and there's some ones that have targeted young people in schools so they can understand the issues associated with opioids. And then in Vermont in 2014, the whole state, the governor used the entire state of the state address pretty much to address drug overdoses. And the Ithaca plan, which is near and dear to me because I went to college at Cornell, and of course, which is in Ithaca, the mayor of Ithaca, who also was a Cornell grad, developed this plan to address the substance use, particularly this opioid overdose epidemic. And one of the things that was suggested in there was a supervised injecting facility. And this caught national attention for this because, and of course, it's very controversial, but these are the things that people are seeing, and it's, of course, very catches attention, and that's what we need, is to catch attention, and in order to get them to work on this. And then, of course, internationally, pretty recently, Canada has legalized heroin prescriptions. And, of course, this is for people who have severe addiction and who, for other things, are not working for them. So this is really a resource that's not used for most, but it is available. So Health and Human Services had developed some priority areas in early 2015. These are really the things that you hear as ways to address this, and things that the federal government, when they provide grants, are asking people to do. And it's training and education on informed prescribing, increasing the use of naloxone, which can be used to reverse an overdose, and expanding the use of medication-assisted treatment. So recent national efforts include community forums by the Office of National Drug Control Policy. So Michael Botticelli went around, as well as with his staff, to many different communities that have been hit hard by this epidemic. And they've really discussed how this affects the community and what can be done to address it. And then the Comprehensive Addiction and Recovery Act, which some of you may refer to as CARA, was signed by President Obama in July 2016, and this really followed the prescription of the Health and Human Services to expand the availability of naloxone and medication-assisted treatment, increase the number of prescription medication disposal sites, and to strengthen the prescription drug monitoring program. So this was signed. Unfortunately, it was signed without funding for a while, and then later, a very small amount of money, $7 million, was appropriated later. But of course, the money that was supposed to go along with it was $181 million annually. So we needed to figure out some other way to get the appropriate funding to address the problem. And the 21st Century Cures Act was suggested, and this bill has been going around and kind of floundering for a couple of years. And some new pieces of legislation were put into this, including the opioid piece that here we're trying to address and tried to address through CARA. So it offers $1 billion over 2 years to combat the opioid abuse epidemic, as well as a number of other things, including cancer moonshot, the brain initiative, working on Alzheimer's, and then there's also fast tracking the putting drugs through the process to get it out to the market. And so, excitingly, it passed the House. It was a bipartisan thing, and it passed the House and Senate just in the last couple of weeks, and was signed by President Obama yesterday. So that means that, along with the signature, the $500 million is set for this coming year, and then, of course, it needs to be, I guess, signed again or approved in order to get the remaining $500 million for the following year. And then, actually, also pretty recently, at least part of this, expanding access to medication-assisted treatment and buprenorphine prescribing. So physicians can obtain a waiver to treat up to 275 patients now, up from what was the limit of 100. And physicians, around the time this waiver came out, about 2,500 physicians had completed that. So that's very good for increasing access. And then, just very recently, nurse practitioners and physician assistants are also going to be able to prescribe buprenorphine after meeting a 24-hour training requirement. This will start in February 2017. And then it might be up to 100 individuals who they can provide the drugs to in about a year later. And then also the first ever Surgeon General's report on alcohol, drugs, and health came out on November 17th. And this outlines the neurobiology of addiction, prevention, treatment, recovery, and healthcare systems. So this is available online. You can get the full report as well as the executive summary, and there's also the National Council provided a toolkit on how to use this with your community. So this is all very good in showing that a lot of attention is to be paid to this issue. So what do we know? And of course, there's a lot of great efforts going on, but this is not enough. So a lot of these things that have been brought up are very far downstream. So they are prevention, preventing opioid overdoses, for example, using naloxone. But we need to start very early. Think about that chart with the 15 to 19-year-olds, where there's very little in terms of overdose deaths. That's where we need to start, because we can do these things to prevent even the ever using opioids. So we need true prevention. So of 20.8 million people with a substance use disorder, only 1 in 10 receive treatment. Of course, we need to start before that. So waiting until after adolescence is too late. Most addictions start with early initiation of alcohol and marijuana use in adolescence. And the statistic is that 90% of addictions start with use before the age of 18. So young adults who use alcohol and marijuana are 2 to 3 times more likely to subsequently abuse prescription opioids. And then to look at the numbers, the National Survey on Drug Use and Health estimates that 2.9 million adolescents currently drink, 1.5 million currently binge drink, 257,000 are drinking heavily, and 1.8 million currently use marijuana. The Monitoring the Future survey results for the past year actually just were released in the last couple of days, and but the good news is that a lot of use among adolescents is decreasing, and among marijuana it's plateaued, about it stays the same. So that's very promising, but as you can see, there are still, the numbers are still there, and we need to work to prevent this. So where does SBIRT fit? And it fits in the conversation about how to address the opioid overdose epidemic. So, as I said, it's not just screening for opioid use and referring to treatment. It's an upstream intervention to prevent and reduce alcohol and marijuana use, and ultimately prevent any initiation of opioid use. So there is emerging research that shows the reduction in alcohol and marijuana use among adolescents, and it's also shown that it can prevent initiation as well. It shows that there are intentions to use have been reduced, And so all of the stages along how it would impact actual use are very promising. And then, of course, it's low cost and minimal risk. So even just in this past year, the American Academy of Pediatrics released another statement recommending SBIRT. And really, they've come out and said, and there are other statements as well, that adolescents actually may derive the most benefit from SBIRT. And thinking about it, you can see that adolescents have the most life ahead of them. And if you can start impacting this early, they will derive the most benefit, because all of those negative consequences which adults are experiencing, it can be prevented among youth. And the American Academy of Pediatrics also stresses that there are great population benefits to be gained, even from minimal reductions in substance use on an individual level. So that's a very important thing to note, because sometimes when SBIRT is looked at, it's looked at in and of itself, and a lot of interventions in and among themselves do not show huge changes in outcomes, but they show a very significant change. And coupling these interventions with other important interventions is how you make changes. So SBIRT is not being implemented. Less than half of pediatric providers report screening, and only 16% use standardized instruments. So, of course, using a standardized instrument is very important, because it helps improve appropriate identification of those who are using at risky levels, and then also being able to connect them with the appropriate level of intervention. A lot of times when providers rely on their own clinical impressions, they fail to identify appropriately. So they identify, usually they don't over-identify, but they under-identify, which leads a lot of individuals who do not get intervention or treatment that would benefit them. And then subsequently, only 30% provide brief intervention. And of course, the barriers to providing SBIRT, and I think a lot of you guys understand yourselves as well, trying to implement SBIRT is time constraints, lack of self-efficacy, and perception that it's really not their responsibility to address substance use, because it's the responsibility of someone else, maybe a substance use or a treatment provider. And of course, all of these factors are preceded by a basic lack of awareness by both clinicians and practice doctors. So of course, you can't implement SBIRT if you don't know about SBIRT. And then usually when you do raise awareness about SBIRT, a lot of providers think they're already doing that, but really what they're doing is asking some questions about substance use. And then, of course, without a standardized tool, you don't really know what to do with people indicating that they are using alcohol or are using drugs. So getting to the main point of this presentation is that we need to raise the profile of SBIRT. And to do this, we need to leverage the momentum in the fight against the opioid overdose epidemic. So what I mean by that is here we're all on this webinar we work in the SBIRT field, whether we're actually implementing SBIRT or we're working at an administrative level trying to increase the spread of SBIRT across, I don't know, a state, across a region. But we have the ability to talk about SBIRT, and we need to be talking about it along with how this can address the opioid overdose epidemic. So we need to add it to the discussion. So of course, as I was saying before, there's a lot of attention on this. We have news stories on TV and the newspaper. We have documentaries coming out. We have legislation being passed. We have when that legislation is passed, we have it on the ticker tape and scrolling across the bottom of the screen. And right now, we need to, the only things that are really being talked about, even though prevention is mentioned, the only thing that's really being talked about is medication-assisted treatment, naloxone, safe prescribing, and so we need to have, if SBIRT can get really added to this conversation, it can really garner the attention and maybe get some more funding so we can actually have this implemented on a wider scale. So what I'm saying here is that when discussing SBIRT, place it in the context of fighting the epidemic. I think this is what people want to know, how it can be used to help with the things that are really impacting the communities right now. So we need to let policymakers know that we can't ignore upstream prevention, for which SBIRT plays a key role. So this can be done, and I always like to bring up the Community Catalyst project, and this is funded by the Hilton Foundation. Community Catalyst has done a great job on this project, really working on a slightly smaller scale, but on this type of effort. And so this project works typically with adolescents, for adolescents, I should say, and a team. It's ongoing team of consumer advocates and state and local policymakers, and it's focused on 5 states: Georgia, Massachusetts, New Jersey, Ohio, and Wisconsin. So what they're looking to do is to educate the public about SBIRT and advance policy initiatives. So really, ultimately, if they can encourage insurers to pay for SBIRT, this will help to promote the use of SBIRT. It also provides coaching and support to help states identify policy priorities, mount effective campaigns, and share best practices. They have had some pretty good campaigns explaining what SBIRT is and that it's done universally in healthcare settings, and sharing best practices among the group and out nationally as well. So what was very exciting about this project is that fairly recently in Massachusetts, it led to the passing of a bill requiring SBIRT in schools. And I think it was 2 different grades that required this prior screening and have trained individuals ready to provide brief intervention. So, of course, I provided a link on the bottom of the screen if you want to read more about the Community Catalyst project. And so the goal here is that by raising the profile of SBIRT, we can help to increase support for continued research, first of all, because right now the U.S. Preventive Services Task Force does not recommend SBIRT for alcohol or drugs among adolescents because it's insufficient evidence. So this is not recommended, and it just doesn't provide a recommendation because it has insufficient evidence in the research. But the research is emerging, and there's a lot of promising studies out there, but we need to do more research so that we can have that recommendation from the U.S. Preventive Services Task Force. There's a lot of difficulty, I'm sure that a lot of you know, conducting research with adolescents for a number of reasons, and then also showing positive outcomes, because just in general, as someone goes from being a young adult or a young adolescent to being an older adolescent, there's just a natural progression of increased use. So with all these things, we need to focus on that continued research. And then we need to help attract funding that helps translate that research into practice. And of course, practice and then strengthen the infrastructure required for successful implementation. So we need to be able to have the providers necessary to conduct SBIRT, and we need to be able to have billing systems in place, have electronic medical records in place. So without talking about this and just leaving the statement as being prevention, we're going to lose a major opportunity. And then, as I previously mentioned too, fighting the epidemic is a multi-pronged effort. So SBIRT needs to be added as an upstream intervention, really focusing on prevention alongside, as I said, all of these other things. So talking about it in this way, it has a place, and I think this is how we can really promote this intervention, because we've been talking about this for years and years, and still the research comes out when people conduct surveys saying that SBIRT is recommended by the American Academy of Pediatrics, but it just isn't being done at the level that it should be. So fairly recently, I published a commentary, which is just a 2-page version, basically, of what I presented, but of course I presented with a little bit more detail. So if you're looking for something to, I guess, either cite when you're presenting to a group or something to hand out that provides the same message, this is it. So I just wanted to share that with you. If you need any help accessing it, you can contact me after the presentation. And now I'm going to open it up to questions, and that's my email address if you'd like to contact me at a later point. So thank you.
Thank you, Brett. I want to remind our audience that if they have questions, they can send those to us through the questions panel, and we will read them so that you have them. The first response we received is more of a comment or a point of information. This audience member is in West Virginia, and they've been implementing SBIRT in their county's middle and high schools for 4 years now and have seen some impressive decreases in reported substance use among their students on the PRIDE survey. I know you mentioned the Massachusetts bill that was passed. Do you know if they have any preliminary data related to, whether or not that's been effectively implemented in their schools at this point, or is it still too early to really discuss that and know exactly how that's impacted things in their state?
Thank you for your question, and that's very promising. I'm glad to hear all that work that's been going on in your schools, and I think it's too early. I would have to check, but this was fairly recent, and I'm not sure when the exact date of implementation started. It might have been the school year, but that would be very interesting to see their data on that. So, I mean, I can look into that, but my guess is that there's no data currently available.
Okay. The next question is, what is your experience with and opinion of the CRAFT 2.0?
Thank you. That CRAFT 2.0 was recently released, and I think it's an improvement. And with the recommendation of the developers to use this tool, I agree with them. And there really is a minimal change. The change is in what I guess you could call the pre-screen questions, the first 3 questions. And it's really trying to get an honest, to ensure an honest answer from the youth, because instead of asking them, have you ever, had alcohol more than a few sips, yes or no? And really, it opens itself up to the socially desirable response. If you instead ask how many days did you, or how many times or days did you have alcohol, then it sounds like it's something that people do. So if you had alcohol, then you could say, 1 day or 3 days, because it doesn't. What I mean is that it doesn't really. It's more stands up and prevents the socially desirable response, because it's really something that people do. So all you do is you're reporting the number of days. So I think that it really helps to identify more youth who may be using alcohol or drugs at a risky level.
Absolutely. So the next question slash comment is an audience member who's an adolescent medicine fellow and would like to put together a presentation for peers, residents, and medical students. Would you be able to provide your list of references for today's presentation?
Yeah, well, the references are, the links are provided at the bottom. I didn't develop an actual, formal reference list, but if you would like a formal reference list, I can send that. You can send me an email after the presentation.
Okay. The next question, is there any type of prevention policy to addiction of prescribed opioid medications that physicians need to adhere to?
Can you repeat that question? It kind of cut out a little bit at the beginning.
Sure. Is there any type of prevention policy to addiction of prescribed opioid medications that physicians need to adhere to?
There's the CDC came out with and it was at the beginning of this year, I think, with guidelines for prescribing, and I didn't provide a link to that, but I'm not an expert in that area, but I would refer you to the CDC guidelines on that.
All right. The next question is from an audience member who started integrating SBIRT at a large healthcare organization within primary care and other health services a couple of months ago. And she asked, do you have any insight or recommendations about how to really gain support and buy-in for the project?
I really think that, well, first of all, it's important to, as I said, talk about what's going on with opioids today and how it impacts communities, but how SBIRT fits into that. I think that in today's, the way things are going on today, is probably the #1 way to get attention for it and get buy-in. And then, of course, it's also important to just really, first of all, show that it doesn't really take much additional effort to implement it in a workflow, and that you're talking about using a standardized screening tool. And I think one of the key things when you talk about SBIRT is emphasizing that the importance of using a standardized screening tool, because it really goes along with other issues as well. It's the same thing. I mean, people asking randomly, like, you don't use alcohol, do you? Or, in those ways, it really hinders your ability to identify and provide appropriate intervention. So this really, and what I always like to say when I'm trying to promote SBIRT is this is standardizing a procedure that you probably do some of already. It just makes it easier, and that's what I've heard from sites that I've worked with, that really this is standardizing a lot of things that they're already doing, and it just simplifies it. So that's what I would say. It really provides step-by-step guidance on how to work with people along a spectrum of use. So from people who are not using, it's the ability to provide education and prevent use and prevent more severe consequences. It's the ability to provide an early intervention, and then it's also the ability to connect someone to treatment when necessary.
Excellent. The next question is from a group of PharmDs who are working at a drug testing laboratory. They've had some issues with pain management providers, primary care physicians, and OBGYNs being able to implement SBIRT programs. Most physicians they work with aren't aware of the program, and many pain management providers quote unquote fire their patients with a positive drug test. And the OBGYN just doesn't have the resources to refer patients for addiction treatment. They've attempted some education, but understand that providers have time and staffing constraints. They feel they're in a unique position for intervention since they can easily identify patients who are at risk given their drug testing results. They've talked about implementing a program and offering it to providers. However, they're unsure whether it's covered by telehealth reimbursement and whether PharmDs are appropriate providers for the service. Do you have any insight on that situation, or have you heard of a similar model that might be working somewhere else?
Well, I would think that PharmDs are very appropriate, and SAMHSA provides different types of SBIRT grants, and one of them they have an SBIRT training grant where they try for institutions to apply to so they can train their students to do SBIRT, and then those students can then go out and when they graduate do SBIRT and first of all be familiar with it, and then it's able to spread actual implementation on a wider scale. And fairly recently, it was actually I think in the last RFP, request for proposals, they included pharmacy schools, and really when people are coming in, first of all, a lot of people come in to get medication, so this is a real opportunity to screen and identify individuals. And then also there are contraindications with certain medications. It's a very good opportunity to educate patients when they get their medication. So I definitely think it's very appropriate. I know that there are time constraints placed on a lot of providers, and then there's drug testing, and of course the consequences of a positive drug test. The important thing with SBIRT is that, first of all, the screening being using a standardized screening instrument, a questionnaire, and then it being in a confidential setting, that it's important to stress that if there is a positive response, say to drug use, that the person will not there will be no legal consequences or any consequences regarding employment. So confidentiality is very key to the SBIRT program. And then, of course, there are ways to streamline SBIRT and automate it as well. First of all, a lot of screening tools have a pre-screen, so it will shorten the amount of time that it'll take to do a screening, particularly if someone is not at risk. It will pre-screen negative, and then it'll be done. And that can actually be done self-administered. It can be done using a tablet-based or kiosk-based. It can all be automated, and then a full screen only for those who pre-screen positive. And so it's just, and then there are SBIRT programs built into electronic medical records, which helps provide the information to the provider of what should be done. It lacks positive screens, and the person can go in, they can get notes, see what was brought up on the screen, and then provide tell them what level of intervention to provide based on that screening. So, I mean, there's a number of different things that help to simplify the procedure, to streamline it into existing protocol in order to, I guess, work with the practice environment that you're currently in, whether it be a busy practice environment with little time to work with patients, or maybe there are some practice environments, too, that you have more time to work with patients.
Thanks so much for that great answer, Brett. I hope that is a lot to weigh over, but I think some really good points there, especially about the pre-screens that can save so much time, and there's a good evidence base for them that you know, they are sensitive and they do identify people who could benefit from, you know, a brief intervention or referral. So what a couple other people have asked us if there are any resources or references for places that are implementing SBIRT into school districts, and if there are any additional models for SBIRT in schools on maybe how to get teachers involved in the classroom.
I would say, I mean, it sounds like West Virginia is implementing SBIRT in schools, and because of course I don't know about everything that's going on. I would say Massachusetts is a really great example, and of course Community Catalyst could provide some context regarding the work that's being done there. So I think that there really are leading the way for SBIRT in schools. I think they would have a really great example. I know it's going on in Wisconsin as well. There's some initiatives going on. It has actually been going on for a number of years. In terms of it involving teachers, it does become difficult because, you know, we're talking about socially desirable and then what kind of consequences there may be. There's a number of levels. First of all, when a student says alcohol is also illegal for people, all students at that age, as well as drugs, disclosing that could lead to legal consequences. It's not confidential, so it could end up getting principal. There could be consequences regarding school, and then teachers provide grades for students. So there are a lot of issues there. But what I have seen, and I think is important for teachers, is to be trained in identifying these types of issues. For example, there's mental health first aid training is being pushed in schools for teachers, and that provides these individuals the ability to recognize a lot of mental health issues, and if there is a module on substance use as well. So those, that type of training, I wouldn't necessarily, but those are for identifying and then referring to appropriate intervention or appropriate services. And also, classrooms are an opportunity to provide education. A lot of the work that I've done with SBIRT, I've really tried to promote SBIRT in school-based health centers, because those are actually clinics, healthcare clinics that are located in a school. So they are really a separate entity from the school, and they are covered by HIPAA. They're run by hospitals and diagnostic and treatment centers. And a lot of the times that they have collaborated well with schools, and they go out into the classrooms and provide presentations, provide education, and then of course offer students the opportunity to come into the school-based health center where they can get a screen, where if necessary they can get an intervention with a trained medical professional. And this is all, as I said, covered under HIPAA. It will never end up in the student's education records, and also won't be shared with the parent really unless the student is willing to have it shared. A lot of times it is important to involve a parent, and the provider will ask first. And if it's really a high screening score indicating a referral to treatment, the provider will really stress the importance of including a parent. But there are really, it's, I guess, a simpler process to do this in a medical setting like a school-based health center, but there are very good examples of SBIRT in schools. And I think, in my opinion, I would go to Massachusetts to ask them about all their experience, because I sat in on some of their presentations and been very impressed. I hear that West Virginia is probably also a great resource, and they're seeing positive outcomes, and Wisconsin as well. And Dr. Rich Brown is a big part of that initiative, so he would also be a very good contact person.
Thanks. And as a follow-up to that, we do actually have someone on who can comment on the West Virginia project. So at this time, I'm going to unmute Hannah Stewart to make some comments about the work that they're doing in West Virginia and what successes they've had so far. Hannah, whenever you're ready, you should be able to speak. It looks like you need to unmute yourself, and then you should be able to speak to everyone directly on the webinar.
Okay, hi. This is Hannah Stewart. I'm a licensed graduate social worker for Morgan County Schools and with the Morgan County Partnership. I'm sitting here with Jeremy Spear, who's a licensed graduate social worker doing SBIRT facilitation, and Gary McDaniel, who helped begin the pilot program for this 4 years ago, who's also an LICSW with the Morgan County School System. I'm sorry, what is it that exactly that you'd like me to go ahead and expound on?
Just what successes you've had so far with your program, and you know, what systems and design you have in place for ensuring, you know, the confidentiality and those pieces that people have asked some questions about.
Sure. So I'll talk a little bit about our setup, and then I'll let Mr. McDaniel talk a little bit about our successes, as he's been here with the program longer. So our setup is that we send out to all parents an opt-out letter, so that parents are informed that we will be coming into the school, that we will be providing confidential services. And through that opt-out letter, we got just a handful back from each school system, but parents are able then to decide whether or not they want their child to participate in that. Most of the time, parents are okay with that as long as they've been informed that their child is going to be screened. So then we do the screenings within the classroom setting. We usually work with a team of teachers to just do all of their classes that week. And we do the screenings within the classroom setting. We begin by doing a little bit of a brief intervention, talking about the positive choices that kids are making, especially now that we're seeing that positive data come back, talking about confidentiality, talking about the process, talking about the student's ability to decide whether or not they want to participate, even if they participate in the screening, that they don't have to participate in interventions or brief treatment. So we do that, then we add up all of our screens, we score our screens, and then we go back into the school system and do a confidential setting, usually a small room in the counselor's office or in the main offices, where students can be seen and provide and still comply with HIPAA, FERPA guidelines. We do not share SBIRT information with or scores with teachers, counselors, administrators, and I think that's kind of our basic setup there. Gary's going to talk a little bit about our progress.
Well, we started out just doing the substance abuse SBIRT with the craft. And we did that. We've done that for 4 years. This is our second year for adding the mental health component. You know, where we use the PSP that looks for anxiety, depression, and trauma. And then we also do brief interventions for those. And then, of course, you know, for students that have a higher need than we can really meet within the school day, either of the substance abuse nature or of a you know, more mental health nature, then we refer them to treatment. We have a good relationship with our local providers, so we're able to facilitate them getting into treatment a little more expediently than they might be able to manage on their own. Because we're working with all clinical social workers, we don't, you know, we have a right to extend that confidentiality to our students, that privileged communication, in a way that school personnel don't. Even though we're employed by the school, school counselors and administrators and, you know, whatnot have certain kind of reporting mechanisms that they have to utilize. We, of course, have to report if there's, you know, if we, in our brief intervention, discover child abuse or risk of, yeah, sexual abuse, risk of harm to self, risk of harm to others. We obviously have to address those, but just the substance abuse information itself remains confidential. It's not a part of the student file. It doesn't go to the administrators. It doesn't go to the teachers. It doesn't go to the parents. The only time where there's an exception to that is if we get to the point where we need to refer them to outside treatment. And then obviously the parent has to participate in that for obvious reasons.
But that's a conversation that we have with those students before we do that. So it's not that the student is unaware that their parent is being contacted.
So one of the things we do every 2 years here is a PRIDE survey, which looks at students' risky behavior. And in that it looks at substance abuse. So for instance, over a 2-year period while we've been doing the SBIRT, our student self-reported cannabis use in the last 30 days went from like 10%, this isn't the exact number, but I don't have that data sitting right in front of me, but we could certainly provide it. But it went from 10% to about 3%, like 3.4%, I think it was. Their last 30-day alcohol use also dropped pretty precipitously over a 2-year period. Their self-reported tobacco use dropped precipitously over the same 2-year period. And we saw declines in self-reported use in every single drug category that we look at in the PRIDE survey. And, you know, obviously there are lots of other things going on in our community, so we can't say that it is only SBIRT, but that's the thing that we use to specifically target substance abuse. Most of the things, though, that have been going on in our community are a heroin epidemic and a rising poverty rate. In the time that we've been doing SBIRT here, our poverty rate has gone from about 50% to over 70% for our school system. West Virginia is in the midst of a terrible heroin epidemic. I will also say, too, that I do also, I recently started working with Marshall University in the southern part of the state, and we're trying to replicate, we're starting to begin to replicate the same model in other counties in West Virginia that we have here. But it is not a state-level initiative. However, BHHF, our state's Department of Behavioral Health Facilities, does provide us with grant funding to employ our SBIRT specialists who do our screening and our brief intervention and make the treatments to referral, or referrals to treatment. I hope that's helpful.
Oh, absolutely. Thank you both so much for being willing to share with our audience, you know, some of the work that you've been doing. We hope that things continue to be promising as you continue on in your SBIRT endeavors.
Thank you.
We're really sold on the model. We think it's just an outstanding model. And but I will say this though, I think this is an answer to someone's question along the way, that when we first started, we did get a lot more pushback from parents. They didn't know if when we said screen, if we were talking about a urine drug screen, if we were talking about some kind of invasive thing. So there was some work that we had to do initially just with the community, meeting with some parents, putting some information in an article in the local paper and things like that to just help people understand that it was, you know, voluntary, that it was confidential, that it was not any kind of invasive screening. It was just answering some questions. But once people understood what it was, we've had a really, really high acceptance rate in the community. So.
And I think that part of that is that we got teacher buy-in, but we do a lot of community outreach, not just SBIRT based, but a lot of community outreach and classroom outreach on stress management, on self-regulation, on academic support, on self-esteem. So part of our SBIRT model and working in the schools is that we're providing not only that individualized treatment, but we're providing services to the whole school system universally, as well as small group activities that help teachers really see us as a strong positive presence in their school, and that's helped as well.
Excellent. Well, it looks like we are about out of time here, so I'm going to go ahead and go over some of the ending housekeeping here. I want to say thank you to everyone for your participation today. We had so many great questions, and I again want to say thanks to our presenter, Brett Harris, for such a great webinar and for getting us started with such a great discussion. At this time, I'm going to go over our evaluation and CEU instructions. You'll receive a few emails from us following this webinar. In these emails will be a link to the recording of the webinar as well as a PDF version of Brett's slides. Also included in the email will be a link to our evaluation. Our grant evaluators are both required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintaining our funding and continuing to provide quality education and materials. Your participation would be greatly appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a place to request your NADAC and PCB CEUs. Should you choose to skip the evaluation and proceed directly to the CEU request, please leave all answers blank on the evaluation. Following the webinar, you'll also have a certificate of attendance available for download in your MyIRETA profile. You don't have to do anything to request that. It will be there an hour after the webinar for you to download and file away as you see fit. Again, we want to thank you all for your participation today. And if you have any questions for us, please email us at info@ireta.org.